I am Dr. Bharat Koyani, MD Pathologist, residing in Rajkot, Gujarat, India. Today we will discuss a clinical case of gestational diabetes mellitus. A 21-year-old pregnant lady presented in an antenatal clinic. She was investigated. Her RBS was 90 mg/%. Other investigations were normal. Up to the time of delivery, RBS was not done. After delivery, the neonate developed seizures and loss of consciousness at the time of 4 hours. And after 8 hours, the neonate died. The cause of death was not known to the treating physician. The whole family was disappointed. After 3 years, the same lady presented with pregnancy to another OBG clinician. She was followed in the same manner up to the time of delivery. At the time of delivery, the patient complained of burning micturition and urine was tested. The urine showed 4+ urine sugar. This alerted to the clinician and she suspected gestational diabetes mellitus and the sugar was 190 mg/%. The clinician called pediatrician. The blood sugar of the neonate was continuously observed. Neonate developed hypoglycemia and the child was treated with glucose concentrate and the whole process saved the life of the child. Now this was a case of gestational diabetes mellitus. What are other complications of gestational diabetes mellitus? If the gestational diabetes mellitus is present in the first trimester, the fetus may develop atrial septal defect, ventricular septal defect, sacral agenesis, pancreatic anomalies, etc. Now, if the gestational diabetes is present after 20 weeks of gestation, the mother may develop hypertension, preeclampsia, hyperamniosis, etc. and also caesarean section delivery. The after delivery fetus may develop hypoglycemia, shoulder dystocia and other complications. The long-term complications of the gestational diabetes in the mother as well as child is the development of type 2 diabetes after a long period of time. Now this is the importance of detection of the gestational diabetes mellitus. Now what to do to screen and diagnose gestational diabetes mellitus? One institution known as IADPSG suggested the guidelines for the screening and detection of the GDM. This institution studied HAPO criteria and other criteria given by many institutions and recommendations were given to detect and screen the gestational diabetes mellitus. The recommendation given by this IADPSG is the patient is called fasting after 8 to 10 hours of fasting in the morning and the first fasting sample is taken. Now after taking the fasting blood glucose sample, the 75 gram of glucose is given to the patient and at the 1 hour and 2 hour samples are taken. If the fasting blood glucose is 92 or more, or at 1 hour the blood glucose sample is more than 180 mg/%, or if 2 hour sample is more than 153 mg/%, the gestational diabetes mellitus is confirmed. Now, due to the non-compliance of the patients in India, the DIPSI has suggested criteria in which there is no time given to the patient. No fasting criteria are required. Whenever and whatever time is there, the patient is given 75 gram of glucose and only one sample at 2 hours is taken. If the blood glucose is equal or more than 140 milligram %, the gestational diabetes mellitus is confirmed. Now this is a compromise of the ideal thing. As far as the ideal thing is concerned, we should follow the IADPSG criteria. What should be the protocol for detection of gestational diabetes mellitus? Each and every patient must be tested for gestational diabetes mellitus. Means it is a universal screening of every pregnant lady. Now what should be the follow-up? When there is a first visit of the patient in the antenatal clinic, the pregnant lady must be screened for gestational diabetes mellitus. Even in the first trimester, testing is carried out. If the patient is negative for GDM, then again repeat of the test must be done between the 24 and 28 weeks of gestation. If again the test is negative, it should be repeated in 32 to 34 weeks of gestation. And if it is negative, then there is no diagnosis of GDM. If the diagnosis of GDM is confirmed, even after delivery, after 6 to 8 weeks, the test is repeated whether there is an existence of the glucose intolerance is present or it has vanished. Now it is my humble request to prevent the complications to the mother and the child. We should follow the IADPSG criteria. If there is a non-compliance of the patient, we can also follow DIPSI criteria. So this is my humble request to go through this gestational diabetes mellitus literature and follow in our own clinics. Thank you very much.